everybody. Thank you so much for joining us today. This is a learning exchange, so I hope those of you who are in listen mode only will get on so that you can join into the conversation. So this is not a webinar, so to speak. I'm not going to be giving you a lot of information. We're going to be using the hour that we have together to share information with each other. And so just so you know, this learning exchange is on development of policies and procedures to ensure family-driven practices. And this came out of a webinar we did called the Nuts and Bolts of Family-Driven Care. And what happened on that initial webinar was that we did a poll, and we asked the participants on that webinar what were some of the challenges or hurdles that they faced in really implementing family-driven practices. And one of the things that we heard loud and clear was that in most cases there were no policies or procedures that mandated or even enforced the fact that communities and system of care grantees wanted to do things in a way that would be considered family-driven. So people felt strongly about the fact that if things weren't in policy, if they weren't written anywhere, then it wouldn't probably be a part of practice on a regular basis. So I'm going to get started. I know we still have people joining us. So just a little bit about the National Federation. For those of you who may not be familiar with us, we saw a lot of folks who were joining these webinars and conversations for the first time. So the National Federation is a national family-run organization, which means that we are parents and caregivers of children who have severe behavioral and mental health challenges. And our vision is that through a family and youth-driven approach, all of our children and youth with severe mental health challenges will grow up and maximize their potential. And we offer support to the young people and their families. And so the National Federation does that kind of in a threefold way. We do a lot of advocacy on a national level for the rights of children and youth. We provide leadership and technical assistance to family-run organizations and other child-serving agencies. And then we collaborate to transform mental health care in America. So a part of what we're doing today is offering some of that technical assistance that's in our mission. So what you see now is our goal for today. Our goal is to confirm the need to have policies and procedures in place to ensure that family-driven practices actually happen. And so that's what we're going to discuss. And then we're going to share examples of what these policies and procedures should entail. What should they look like? And we want to also find out where there are examples. If you have examples in your community, in your state, within your system of care, within your collaborative or governance structure that you're a part of, or any kind of committee you're a part of, if you have any examples of what some of these policies and procedures are, we certainly would like for you to share those with the group so that other folks on the call can maybe learn from those examples and go back and hopefully implement some of those. So I want to take just a few minutes to find out who's on the call. We have a lot of folks on the call. So if you can quickly tell me who you are, where you're from, and what your role is, and just those few things. So if you can unmute, if you've muted, unmute your phone and kindly introduce yourself. Not everybody at once.
Hi, Sandra. It's Barbara Huck, and I do technical assistance for the National Federation of Families for Children's Mental Health.
Hi, this is Rosemary Libretto from the FSO in Bergen County, New Jersey.
Welcome.
Hello, this is Jackie Mitchell from Kalamazoo. I'm with Kalamazoo Community Mental Health.
Welcome.
Hi, Beth Pfister with Cardinal Innovations in North Carolina, the managed care organization in 16 counties.
Great, welcome.
Hi, this is Janelle Adair from Tahlequah, Oklahoma. I'm with Cherokee Nation's Project Hero. I do the media as well as the youth and family coordination for our program.
Great. Welcome.
Hi, this is Teresa King. I am a family content specialist for the National Federation of Families, Children's Mental Health, working with the Georgetown National TA Center as the family representative.
Great. Thanks, Teresa.
Hi, this is Rachel Gay, Child and Adolescent Mental Health Division in Hawaii, and I'm the Family Support Liaison.
Welcome.
Hi, this is Tanya McCullum with Alameda County in California, and I'm the lead family coordinator for early childhood system of care called Early Connections.
Hi, this is Ann Chun with Alameda County also, and working in the same initiative as Tanya called Early Connections. I'm the Cultural and Linguistic Responsiveness Coordinator.
Thanks. Anyone else before we start again? So I hope you all can see the chat box. A lot of folks are introducing themselves in the chat box, which is absolutely fine. So you do have the capacity to scroll up and down the chat box to see who else is on. So I welcome everyone again to this learning exchange. So let's look really quick because we are going to be talking a lot about what it means to have policies and procedures around family-driven practices. So we need to really quickly look at what the definition of family-driven is. And the Federation was charged by SAMHSA a few years ago to work with families and providers across the country to come up with the definition. So it says family-driven means that families have a primary decision-making role in the care of their own children, as well as the policies and procedures governing care for all children in their community, state, tribe, territory, and the nation. And this means that families can be involved in choosing culturally and linguistically competent services, supports, and their service providers. It also means that families should really be involved in setting goals. And when we say setting goals, we're not just talking about setting goals for their children and the success of their family, but setting goals for that community collaborative, setting goals for that system of care, setting goals for those agencies and programs that will be treating our children. So that's setting goals in the broad sense of the word. And so that means that they can help in designing, implementing, and evaluating those programs that serve their children and their family and the children in their communities. And then monitoring outcomes. We want to really make sure that families are paying attention and being involved in conversation about outcomes, what's successful, what needs to be changed, where the strengths are, and where there are needs for improvement. And then also partnering in funding decisions. So as agencies and communities and grants are trying to decide what's the best use of their resources, families should be at the table letting folks know what services and supports are helpful, what are not, where there's a service gap, where we need to be putting additional resources to meet some unmet need that the children and families might have. So some of the questions that we're going to be diving into on this call and that we're going to be wanting, like I said, this is a conversation. We're going to be wanting to hear from you guys on the phone who've done it already and have some policies and practices in place, and some of you who are on the call because you really want to know how to do this. And so we're going to welcome you to ask questions, and we're going to have folks on the call with more experience to respond and answer your questions. So one of the questions is, why is there a need to have policies and procedures in place that speak to implementing family-driven practices? And the second question, is it clear that everyone around the table share the same understanding of what it means to implement family-driven practices? And then another question to just think about is, what are the common misconceptions about this? And so let's start. I'm going to start from the bottom. and ask you guys, what are some of the misconceptions about family-driven practices and implementing family-driven care? Is there anyone on the phone who knows that in your community there may be some misconceptions about that? And it's okay to speak. Well, while you're thinking, I'm going to go back really quick to the definition and tell you one of the largest misconceptions that we hear here at the National Office. The first part of this definition says family-driven means families have a primary decision-making role. And what we have found out that a lot of people interpret that is that family-driven means families have the primary decision-making role. And so we get a lot of questions and concerns from families, from providers, from agency heads, saying that we can't have a system where families have the only decision-making role. And so we always point out that we saying they are one of the primary decision makers, but they are not the total decision makers. And so sometimes when people kind of clear up that misperception, it's easier for them then to be willing to entertain the fact that families should be at the table and should be a part of that decision making. Has anyone had some of those discussions or misconceptions, other misconceptions in your community?
Hello, this is Janelle from Tahlequah. I think one of the misconceptions that we've run into here, it kind of goes along with what you just said. Some people, some of the agencies that we've worked with don't necessarily believe that the family knows what's best for themselves. And it's almost like we have to convince them and talk to them about SOC, what a whole systems of care is and what family-driven means. Because I guess it's the old school way of thinking, well, this is what you have to do and this is what will make your family successful, or this is what's good for you, this is what will fix things. Whereas really each family is different. You know, every family is different. The goals that they have are different. Where they're starting from is different. And so I think we've run into some of the things, like what you were just saying, you know, people think that it's just the family making this decision when they're really just part of the primary resource that we're using to make this plan with them. But like I said, we've run into some old school thinking where they want to tell the family what to do instead of listening to the family and allowing them to have an equal say in their own plan for the people that they care about.
Right, excellent. That's a good example. Any other examples out there? So let's look at question 2. Is it clear that everybody around the table has the same understanding of what it means to implement family-driven practices? Because, you know, well, we can really easily move into jargon where we write proposals and we get at meetings and we use words family-driven, you've got it, culturally and linguistically competent. And if you really get down to it and you start having the conversation, sometimes we're not all on the same page. So can I hear from some of you if you think that folks in your community around your table, do you all have a clear or even the same understanding of what you mean by implementing family-driven practices? How do people articulate that, and is it in writing anywhere?
Sandra?
Yes.
Oh, okay. This is Rachel in Honolulu. I don't know that it's a misunderstanding or misperception here. It's more sometimes a concern about how do you negotiate families' wants and wishes, and when there are some limits in terms of what the state provides in terms of levels of care and so forth. So it's just a little bit of they get a little nervous about negotiating some of those things, although it ought not to be.
Yeah, that's a great point. And I'd love to hear from other folks, because one of the things that we do hear is that families may ask for services or some kind of support that the agency may not readily have at hand. And then I think that's when some of the other things in the definition comes to play. It's around how do we try to reallocate resources or do things like that. Other folks, do you see that as an issue where you are, that families, there's sometimes that push and pull around what families say that they want and need and what communities can provide? I'm sure everybody's not already doing this. Let's look at question number 1 then, and I'd love to hear really some answers on this. Why is there a need then to have policies and procedures in place? Do folks automatically, when they start working with families, do they automatically move into implementing family-driven practices without anything written or without setting ground rules? How did some of you who are doing it, how did you initiate it where you are? How did you start moving toward family-driven practices? And I know several of you on the phone are doing a great job in your states and in your communities.
Can you hear?
Yes, I hear you. Go ahead.
In Kalamazoo, or in Michigan right now, or in Kalamazoo, Michigan, we have narrowed our vision and mission down to some of the guiding values that families identified to implement family practice and family voice into the system of care.
Right. So is that in writing in a document somewhere that folks can share?
Absolutely.
Oh, great. Well, I'm going to have you send that to me. We're going to be able to, folks that have documents and examples, we would really like to get some of those to share with everybody.
Okay.
So other folks, why is there a need to have these policies in place, and do you have them in place?
Sandra, this is Barbara. And,
Barbara.
you know, I think it's good business practice. And it kind of equalizes the playing field for everyone. I did some work in Utah about a week or so ago, and had the ability to pay parents to come and help us in a meeting identify, you know, family engagement strategies. And, you know, I asked the family organization there about what they need family members, and immediately she said, I'll need to go to my policies and procedures. You know, paying family members to do work with us is, you know, an important part of family-driven practice. And it felt so good for her to say that, because then we didn't have to talk about it. It was in place someplace, you know. She could go right to her policy and procedures and let me know how much they pay families to be, you know, to help with a meeting like that. And so it just feels like we're at a place to have those kind of good business practices.
Exactly. Thank you. That's so important. So anyone else, do you all have things like that written to your policies that families are supported to come to meetings, to participate? They get a stipend, they get help with transportation or child care. Are there any examples where you all have some of that written somewhere?
Hi, this is Teresa. When I was in Cuyahoga County, which is Cleveland, Ohio, that is one of the things we did as an organization, was have written down policies, just like Barbara said, exactly how much parents and young adults and youth were going to be paid, whether it was a 3 to 4 hours, a half a day, or a full day, or overnight. We had all those things written in place, what type of trainings that you had to go through in order to qualify to become a speaker for Cuyahoga Tapestry System of Care. So we did put all of that in writing just so it could be clear for our funders to understand what they were paying for and what measurement we were using to keep track.
Great. Thanks, Teresa. That's helpful. So I had a couple of examples. In 2009, the Federation did a family-driven policy academy, and there were about 7 states that came to that policy academy, and the purpose was so that they could really sit down and do what we are talking about on the call today, so that they could really set some policies and procedures in place that were in writing that would help them move forward. So the Arizona contingency, they put in some of their policies that all trainings that they did around system of care, around child and family services, all training had to be done in partnership with their family organization and with their other family partners. And so that was something that came out of that meeting along with some of the other policies. And Illinois and Colorado really did, through some of their state block grant initiatives, their state mental health authorities, they adopted into their language the Federation's definition of family-driven care. So they made sure that that definition was in their language and some of the grants that they were writing so that they could make sure that that got implemented. And then they even put some, wording around how that would look. And then in Michigan, when they were working on their state initiative, they wanted to make sure that the folks in their state who were working on their systems of care and forming teams and leadership committees and governance structures, that those structures had at least 50% family members. And that was huge. And there may be some folks on here from Michigan to let us know if that's still happening. And then Tennessee went so far as to say that they would not have any of their meetings around their system of care work and around building their child and family services without family representation. And so they said that there have been times when they wanted to have a meeting and the powers that be forgot to include or invite families, and that meeting was rescheduled. And they had to make sure that they have family representation. So these are just a couple of examples that I know of that folks are really, really, putting down on paper procedures. So in any other examples out there? I know that you guys are doing it, and I know that some of it was a hard time coming. There's been a lot of discussion in communities around what it means. There's been some, understanding of just how we implement that. So anyone else have some examples other than these listed here where you know that these are some policies and procedures in your community?
Years ago, Sandra, this is Barbara again, and years ago I was in a state and they did they had an interesting policy in place that every other month their team that came together in the community to plan for services, it was really the decision makers of families, and it was really before youth were involved, but now it would include youth as well. But when they came together, every other month it was during the day, and every other month it was in the evening. And whether it was during the day or during the evening, child care was provided for everyone, not just family members, but family members it was also staff that had children, and they could bring them to child care when it was an evening meeting. And so that was just kind of the way they shared the responsibility for trying to be more family-driven.
Yeah, absolutely. So I'm looking in the chat box, and I know some people are on listen-only mode, so they're using the chat box. And so, hi, Wendy. So Wendy Luckenbill talked about one of the challenges is that families, they still use this phrase of being dysfunctional, and they don't think that families have a lot to offer. And she said that's one of the largest misconceptions that, and then I see that Lauren said during family meetings, sometimes input from parents, friends, and even private counselors disregard the parent or the patient and their input. So, and she gives an example of sometimes it's resulted in rehospitalization or them ending up in the emergency room, just not listening to and using the input from families. Um, so I see that a lot of you all are making those comments. And I think that, you know, one of the things that I think that we've been working hard at in this family movement is to really talk about the experience and expertise that families do bring to the table. And it's hard to believe, you know, after so many years of doing this, that there are some places and communities that still see families as in this real tokenized role, and that they don't have a lot to offer, so they don't want to do things in that way. So any other comment about that?
This is Janelle. Oh, go ahead.
I'm sorry, this is Tanya. One of the challenges that we're having in our community, like I would consider a misconception and a barrier, is they see family-driven as costing more money. In our county, the agencies that have family partners really rely on EPSDT billing, and family-driven is like kind of outside of the whole billing process, so there's not a whole lot of buy-in because they're seeing it as, you know, costing them money to be able to provide family-driven care. And I would like to, you know, have a discussion about how to overcome that barrier.
You know, that's a very interesting concept. That's one that I hadn't heard. And I think that comes back to what we said earlier around the you know, the misconception of what we're really talking about when we're talking about family-driven care. Now, yes, having family partners and parent support providers is an important service, but because you have that service still doesn't mean that you're doing family-driven practices. And so to do family-driven practices should really be cost-effective, because you would be really having families who are really being served by that agency, by that system of care, by that particular community, to really be a part of your governance, to be at your tables, your decision-making tables, bringing not only their voice, but the voice of other families within that community, and just informing how practices are delivered. And so I think people are confusing that with the only way to do that is through paying the role of the parent partner. That's just one way. But we found that if you have family voice at all levels, and families are saying this works and this doesn't work and we need more of this and maybe a little less of that, that in the end of the day, that's a cost savings. Because how many billable services out there that we have that families are not taking advantage of because it's not a helpful service to them? And how many times have we spent a lot of money around a table making plans and creating programs to find out that they don't work for families? So I do think there is a little bit of difference there, where people are thinking the only way to do this, you know, it's going to cost us a lot of money. So that's a very interesting take on that. Has anyone else heard that and had that as a barrier? That's really interesting. I think we should look into that and do more investigation of that.
So this is Tanya again. I just wanted to clarify the cost. They do feel like family partners means that they're doing family-driven, but the cost is outside of that in terms of cost of getting families involved. For instance, child care, transportation, that whole thing. That they don't, you know, they don't see how they can do that, you know, and stay, you know, just as part of their budget. How can they make sure that families are at the table? I see it as an excuse, but it is a real issue.
Yeah, I can see. But, you know, it's probably one of the most affordable things that they could do when you talk about child care and transportation. You know, I always point out to people that you're not talking about thousands of dollars when you talk about supporting and helping a family attend an hour or 2-hour meeting. Yeah, I do too. And I think that's we've always heard that, but we do know so many communities that have worked around that. And one of the ways to do that so that it can save dollars some, but it's not a burden on the state. I think one of their biggest burden is probably managing and facilitating that process and having staff to do that. So a lot of states just contract with the family-run organization and have the family-run organization do that support and pay through their contract, they can manage the child care and the transportation and the stipends. So, put that into the scope of work for the family org and then, increase their budgets to do that. And, and I think it wouldn't cost as much as people think that it would. Someone else was getting ready to make a comment.
Yes, this is Janelle again. I was thinking about what you had said, and I was thinking about our program. What we're doing here, because it's all child wellness is what we're centered around, but we also offer services to the families because, that's who's the primary resource of everything for that child. One of the things that we are doing here, we offer a Triple P, which is Positive Parenting Program, and we go out into the communities and do these presentations. And as a matter of fact, this morning I was just talking to one of my coworkers, and she has 3 sessions set up because that's how long the sessions are, 3 hour-long sessions, and she's got them for the evening in a neighboring county because we're very rural here where I'm at. And we're offering child care, but what we have to do is somebody from our office, we have a staff of about 12 for 2 grant programs that we're working off of. And we just have to try to coordinate our schedules to where one of us can go with her so that we provide that child care for that evening. And the facilities, we have to try to book a facility that has something like a playground, or even we've done movies. Like we just, there's when we went to a school and they let us into one of their classrooms and we could use their screen there and their smart board, and we just played movies and had popcorn there for the kids. But one of us is usually the one who goes to staff unless the school or that facility will offer their own child care. So we do try to offer those things so that it frees the parent up to be there. And also, another thing that we're doing in the communities, our action committees is what we call them. We have 4 counties that we cover primarily, and each county has an action committee group. And these are people in the community that come together once a month, and we're just a guide. We just tell them what issues do you see in your communities and what's happening. And they get together and they just talk. They talk about stuff that they see that's going on in regards to children's behavioral health or health needs. And they, one of our counties actually said that they needed a pediatrician. They didn't have a pediatrician in the whole county. They just had to go to a family practitioner. Well, they've been working for about 7 or 8 months now, and they are getting a pediatrician. I mean, it was a very long and a very tough process because money, unfortunately, it's not what's good for the community. It's what's good for the people who have money in the community. And the hospital that was there was not very willing to allow this to happen because they felt like it would take money from them. But our action committees are made up of community members, and we try to pair them up with agencies. Local agencies can come in, but we started to see there was a totally different, what the agencies thought was good for this group was different than what the families felt like were good for the group. So we split those 2 groups up now, and now it's just completely community members that meet, and we meet with the agencies and try to relay the services that they can provide to our groups there. But we also have a cabinet on the Hero Project, which is kind of leads to where we're going overall. And our community members make up half of our cabinet, and we also have a youth component on there. So that's something that we've tried to do is to implement community input, family input, and who we serve. So that's something that we're trying to do. And they always tell us families first. When our families come through the door, that they have to feel important. They have to feel like this is what we're here to do is to help you, and not to to greet people, just to be cordial to people and just to acknowledge them. Because I know even going into facilities I've been into, sometimes people just they're too busy. They overlook you, and it does it's very cold, I guess. And you think, God, nobody even cares if I'm here. But that's something that we've tried to do here is to implement families first and let them know that they're the reason that we even have a job. So
right, absolutely. Thank you. I think about this a lot. There's not any other industry that I can think of that would produce a product without testing it and getting input and feedback from the end user or the consumer. So if you think of anything, like somebody who's making women's shoes, they don't make women's shoes and not have a single female test them, wear them, they give them free samples, they get feedback, they tweak them, and, before they put them on the market. And so I think in our healthcare industry, we have just failed to realize that we are building a system, a product that's going to serve children, youth, and their families. And so the best way to build a quality product is to get input from the end users. Who's going to be the recipients of what we are creating, and how do we get their feedback so that we have that continuous quality improvement happening, then to have families involved and stay involved and use the services and give us feedback and be a part of all that decision making. And sometimes as I travel and I speak across the country and I share that with them, it finally kind of clicks in sometimes about how cost efficient that would be to really know from families that what you're producing, and there's a lot coming out now about having a return on investment. We're investing a lot of money in children's services and supports the families. So we've got to know through what we're doing that we're getting a return on that investment, and that return on that investment is our children, growing up and being successful, and our families having all the support and things that they need to make that happen. So that's one of the things that I'm glad that we're thinking about, is how do we talk to folks in the language that they can understand so that they can see the value. I was looking back at some of the comments in the chat box around, and I think all this about not wanting to have families there and not listening to them is we haven't proven that value added yet. We haven't proven what that value is of having that family voice at the table and being a part of driving the system. Is there any other feedback or comments about that? Because I think that may be the root cause of some why it's so difficult to really implement family-driven practices. I'm interested to see what other folks have to say about that.
Sandra, this is Rachel from Honolulu, and a lot of, for professionals, I suppose, research seems to be an important factor in terms of outcome measures, and I've been trying to find any kind of research that shows family engagement and family involvement with their children that shows better outcome measures, and I haven't. Maybe I've been looking the wrong places, but I haven't found as many as I would like to, and I was wondering if you knew of any references for me. I would be happy to look into them.
There are a few things that come to my mind, and I'm hoping other folks on the call would know some. So one that's right off the bat is a non-state study that was done by Beth Struhl and Bob Friedman a while back, and they looked at systems of care that some of the grants who had already graduated and who had the capacity to sustain after they had federal funding. And what they found in that study was the ones who sustained were the ones who had the most family involvement, who had a sustained family-run organization, who was at the table and who really had valued family voice. And those were the ones who really had the highest level of sustainability. And then there's another study that was done by the University of South Florida on, and I can't remember the name of it, but I can certainly find that and send it out. But they did a study around family engagement and family involvement, and they did look particularly in education and somewhat in mental health, but they found that outcomes were better from the population they looked at if the families were involved in all levels, not just with their own children. Mm-hmm. But if they were involved at the systems level and the governance level. So And the last thing is through the national evaluations for system of care. They're starting to do a little bit of that, looking at parent empowerment and what happens when families are empowered enough to participate not only in their services, but in the services of others. And they look at caregiver stress and strain and how when we allow families to kind of shape their services, then they are more able to participate at a higher level. So there's a little bit, but what we do know is that we need a lot more data.
Correct.
And we do, because I think you're right. As long as we have some of these anecdotal things that say, well, we know it works because of this story or that story, I think that you're absolutely right. And so it's been a challenge because people want to automatically connect families being involved at the governance table all the way to improve child outcomes. And it's a long road from one to the other.
Sure is.
So so I think that, does anybody else know about any other research or data that has come out about the impact of family involvement or family engagement?
Sandra, this is Barbara, and the University of Kansas School of Social Work did a research study on peer-to-peer support. Family members were placed in mental health centers across the state, and families said they did better due to the fact they had peer-to-peer support. That's kind of just just a small slice of it all, but in terms of family involvement. But so I think you might be able to go to the University of Kansas School of Social Welfare and find that.
Okay. Yeah, I think I know of some that talk about sustainability and longer parental involvement and so forth, but I guess I was looking for a child outcome, if there was any connection to show family engagement, family participation that had a positive impact on child outcome measures. And I guess I'm being a little bit more far-fetched than I should be.
There is some in education.
Yeah, I saw the education one.
Education, but I don't know. I'm not sure, Sandra, about what she's asking for in mental health, but there is some in education.
Right, and I don't know if it is in mental health, because we have been talking to several folks around helping us really do some research and data, and because of the data set from the national evaluation, it's hard for us to extrapolate that type of outcome.
Yeah.
So what I think is going to happen, which I really hope does, is that at some point we hope that we can get the attention of a university to help the, maybe the family organizations and the national family groups to really start doing some of that kind of data collection, because I think you're right. It's hard to talk to policymakers and the funders around continuing to do this if we don't really come up with some hard data for it. So that's probably on our to-do list.
Yeah, that's
the other person that I would contact that has done some research, and I don't know that she could give you this exactly, but I know Jane Adams at Keys for Networking in Topeka, Kansas, runs a family organization, and she is a researcher. And she's done a variety of different kinds of research, and if she doesn't have it, she may know who does. And I'm sure she's on the Federation's website under chapters or state organizations to find her. Again, it's Jane Adams.
Okay, thank you.
Yeah. And Kimberly Hogewood out of New York.
Right.
Has done some stuff, and mostly around the parent-partner role. And she talks a little bit about child outcome, but I still don't think there's any hard data on it.
I read her, she had a comprehensive report on a lot of the researches, and it was similar to what we've been talking about.
Yeah.
Can you repeat that name, Kimberly what?
Hogewood.
H-O-A-G, Wood.
Yeah, Wood, yes.
One last thing, Sandra, the challenges that I'm having over here is still on stigma, and it seems as though I think still not doing a super duper good job here in trying to help families not feel blamed about the situation of their youth or child, or not feeling less than up to par with others who may not have mental health issues for their children.
You're absolutely right, and we don't talk enough about it, and I think it is a determining factor. It is hard for folks to invite someone around the table if they really think that they are the problem.
Yeah.
So, bringing them to the table as a partner is really a difficult thing. And, I know SAMHSA has kind of moved away from using the term stigma, and I have been trying to really think creatively, but it entails all of it, the discrimination, the lack of access to services, and all of those things that we group into that. And I think we have a lot of work to do around that as well. But I also think, though, if we did have the data that showed the improvement in child outcomes when the families are involved, because families have to be empowered enough to be involved, which then shows that some of that stigma has been diminished. So I think that it could be interconnected in some way.
Yes.
But I still think we have to get that data. I'm looking at the chat box, and Kathy Getting has put a question on here. She said, what do we mean by the phrase done in partnership with family organizations? And I know there are some folks on the call today who represent family organizations, but what we mean by that is the Federation has family organization or chapters all over the country, and these are organizations that we say are run by family members or caregivers or parents who have had the experience of raising children with mental health challenges through many systems. And there are several other family-run organizations that are not necessarily Federation chapters across the country. And so what we try to do is when systems are coming together, forming any kind of community or state collaborative team with agencies, agency heads, and community organizations, whether they're involved in faith-based organizations or whoever they want to pull together to create and sustain services, that they include a family organization representative, so that family organization can bring the voice of those families in that community who are actually being served in that community. So, Kathy, I hope that answers your question, but we do sometimes say phrases that everybody may not understand. So if that doesn't, just you can ask me more. Okay, thanks, Kathy. I see your response. So if you have any other policies, we want to hear about them. And I'm really hoping that people will share any policies they have that are written, that are assumed, that really help support the concept of family-driven practices. So others of you on the phone, can you do you have any other examples of where you have something in writing or that people automatically know? There's sometimes when people know that when they come to a meeting, if they're not families, then they may not have the meeting, or they know that X amount of people need to be family members. Can anyone share any other examples from your state or community or even within your family organization? What I'm hoping is if anyone on the phone, if you have any written policies that you have from your community collaborative or anything, if you can even email those to me, and I'll share my contact information, because we would really like to be able to share with the folks who are on this call. This session is being recorded, and we'll have folks of you who registered, we will have your email addresses. So if folks can share any policies, any procedures, anything that you come up with, then we can share it with the group. So somebody has posted on the chat box the resource that I was referring to. Thank you, Candace. So hopefully all of you can see that in the chat box. and I think other people are trying to get some information. So if you have any information like that and you're willing to share it with me, I would really appreciate it. So are there any questions from participants? And you can look down at the bottom of the chat box where it says Q&A. You can either type it in there, or all of the phones should be unmuted now, and you can ask your questions. So I'm going to pause a minute to see if we have any questions from our participants. Are you guys already seeing examples of where they're doing really good family-driven practices? Do some of you all feel the need to have more TA around how to do the policies and procedures? So here's a question, guys, and I hope other folks can help me answer it. How often do family members feel pressure to seek advanced degrees to be able to get into a paid position doing state-level policy work for children's mental health? So those of you on the phone, have you, in your sites or communities, are they wanting families to have advanced degrees, or do you know that they're pressuring families to get advanced degrees to be in some of these paid policy-level positions? And this is something I hadn't heard a lot about, whether people are being pressured. So Diane from South Carolina, they are not doing that with her that she knows of. What about other folks? That's a very interesting question, because one of the things that the National Federation struggled with, and many of you know that we have a National Parent Support Provider Certification Program. And in order to get, most time when you go after a certification is based on, education requirements and degree requirements. But because we were not having a required degree to be a parent support provider, we really had to go by lived experience and years of experience. And we got a lot of pushback from some of the national accreditation companies around needing to have a degree. So I do understand that, but that's something we say that lived experience is what we're really looking for when we want families to be at the table and offer their support. And so Candace was saying sometimes do they act like they even prefer candidates to have a higher education. So Candace, I'm not seeing it a lot from where I am, but I would love to know if it's happening out there in the communities, because that would be worth another conversation. Anybody else have any information about that? I'm going to wait a few more minutes because I see other folks are typing into the chat box. So Tanya says, we do find it a challenge at the county level in hiring family members with lived experience. I do think that there are, there are some of our funded system of care sites that their fiscal agent may be a state agency, or even sometimes they go through a university, and sometimes they have these requirements around pay scales. And so that's made it really difficult to hire family members within some of these agencies or at the county or the state level because of the structures they have. And so my advice again would be sometimes it's better to contract with the family-run organization and have them to hire the family people through the organization to work with the agency. That's just one way I've seen it done to get around some of the advanced degree requirements. But that's an excellent question, and I think it needs a lot more conversation. So we just have a couple of more minutes. And I just added a couple of resources here for you guys. For you to take a look at it. There's some resources that we have at the National Federation, And all of these resources, of course, can be found on our website at www.ffcmh.org. And you will have access to these PowerPoint slides at the end of this session. So you will be able to click on these live links and be able to find the resource you need. So somebody's also talking about pay scales. And one of the things I can say about that is the family-run organization FRETLA did a webinar through the Technical Assistance Network around how to use set pay scales for parent support providers. So that may be another resource for folks. But it's really, I understand it's really difficult to set pay scales when you're not doing it solely based on education and degrees. But we oftentimes look at lived experience and a number of years that families have been offering these kind of services. And one last thing, I'd like to make sure that everybody remember to save the date for the National Federation's annual conference. Of course, that's always in November, and this year the main conference is November 21st to the 23rd, and it's right here in the Washington, D.C. area at the Omnishurum. So we have moved away from the Grand Hyatt, and we're now at the Omnishurum. And there's one change that I want to make sure that everybody knows about. This year, the Parent Support Provider Institute will be held on Thursday, November 20th, and Policy Day will actually be held on a Wednesday this year. We found out that Congress is going into recess on Thursday, and so we want to make sure that we get those Policy Day Hill visits and those kind of things done while they're still in the D.C. area. So please mark your calendar for the National Federation Conference. Registration is open. Early bird registration ends September 30th, and so the registration fee will go up after September 30th. So we encourage folks to register early and save a couple of dollars. And I thank Candace because she has put up the FRETLA webinar slides that I was referring to. So you guys can see that in your chat box. And this will also be made available to you after this session. This session, like I said, is recorded, so you'll have access to this information. So we're at the end of our hour. I thank all of you so much for being a part of our discussion today, and I appreciate you joining us. And everybody have a really good afternoon. Thank you so much.
Thank you.